No, it's my pleasure to introduce Chris Patriquin, who's an assistant professor of medicine and clinical investigator at University of Toronto. He attended McMaster University for his hematology, did a clinician investigator master's in something or other about public health. I can't remember. And anyway, but then he actually ended up going to Leeds, the home of PNH studies, and did further studies there, and then returned to Toronto, where he's on faculty there. He's really a leader in complement-mediated diseases, particularly focusing on PNH, but as well as in TTP. He's the chair of various national, international advisory bodies in those two areas, and he's a great guy, and he's a terrific clinician investigator who really understands the pathway, so it's very cool to interact with him over the last many years. So Chris.
Thank you very much, and I have the esteemed position of standing between you and your afternoon tea and coffee, I think. So I'll try to keep this quick. Thank you, Ed, and everyone for the invitation to speak to you today about a topic that I probably think too much about, PNH, and I'd like to present some new insights into this rare thrombotic complement-mediated disorder. And before going forward, my disclosures are listed here. Another disclosure is that I am not a laboratory scientist, and I envy all of you, and I'm a bit of a groupie. So I will present some preliminary lab data, and please don't yell at me too much if I get it wrong. I'd like to start, just if it's a mixed audience, talking about the pathophysiology and clinical presentation of what we see in PNH. We'll explore some mechanisms of thrombosis and also thrombotic risk in PNH. I'll talk about the therapies that we have currently available, but also some that are new and upcoming. And I'll finally present a novel approach to studying rare diseases like PNH that may be something that could be used in other areas as well. So PNH is an acquired non-malignant clonal abnormality that affects our stem cells. It's a mutation in the PIG-A gene, which is the first step in formation of the glycosylphosphatidylinositol anchors. And these are anchor proteins to which many effector functions or molecules should bind if the system is working appropriately. And as you can see in the figure here, this is normal blood with evidence of these expressing complement regulators, CD55 and 59, which are bound to these GPI anchors if present, and really regardless of the pathway of activation of complement, classical, lectin, or alternative, we have formation of these C3 convertases, and CD55 is a cell-bound regulator that accelerates the decay of these regulators or these convertases, reducing that forward progression of complement activation. And in situations where there is increased complement activity, perhaps an infection or other inflammatory insult, we can still have progression to terminal complement activation, cleavage of C5 to 5A and 5B, and with 5B being the first step in formation of the membrane attack complex shown here. And we have CD59, which is really the one regulator cell-bound that protects our cells from MAC deposition. So in a PNH context, we do not have that protection. We have increased deposition of proximal complement molecules, progression all the way to quite easily membrane attack complex deposition, and it really takes just one or two of those to lead to intravascular hemolysis. And that is part of that classical triad that you'll read in any first paragraph of a PNH paper of DAT negative hemolysis, but also thrombophilia and bone marrow failure. But we don't, as clinicians, tend to see patients with this fully manifested triad. They'll come with unexplained cytopenias, perhaps refractory iron deficiency anemia, or atypical thrombotic presentations. But they may have really exaggerated chest pain and shortness of breath. Certainly, smooth muscle dystonic symptoms are very common. This can be erectile dysfunction, dysphagia, and pulmonary hypertension, which can be life-threatening. And not surprisingly, perhaps these patients have quite a lot of fatigue and impaired quality of life. And much of the pathophysiology is driven by this intravascular hemolysis. We have unregulated release of free hemoglobin into the circulation, which scavenges nitric oxide. And we have multiple downstream effects of this that we see in the clinic that can have a direct impact on overall survival for our patients, and I'll focus particularly on thrombosis today, but also renal failure, pulmonary hypertension certainly, and other features that may not directly impact survival, but really play a disservice to a patient patient's quality of life. And to put it into a Canadian context, these are data we published a few years ago of patients in the Canadian PNH registry, and I'll direct your attention to the column that says patients on eculizumab, though the rates of the manifestations you see are those which they presented with prior to therapy. So you can clearly see a very highly transfusion-dependent population. Almost 88% had received at least one unit in the prior year. Thrombosis had occurred in over 20% of patients, mostly venous, but also arterial events had occurred. And you can see these very non-specific symptoms that patients can present with, which can explain why it takes so long sometimes to diagnose them. Belly pain in 2/3, shortness of breath in about 60%, dark urine in 3/4 of patients, hence the name of PNH. Fatigue was nearly universal, 98%, and 1 in 5 males had erectile dysfunction. And this is an ultra-rare disease, as I mentioned, around 1 to 5 per million are diagnosed annually in Canada. And of course, to make that diagnosis, it's very simple in terms of a laboratory test, but you have to think about the disease first. And this is a mnemonic that is endorsed by the Canadian PNH Network called the CATCH mnemonic. And as you can see, it stands for cytopenias, which are unexplained, aplastic anemia and MDS, thrombosis, which is unexplained, Coombs negative hemolytic anemia, and hemoglobinuria. And the features or the figures you see above here show you the positive hit rate for when PNH testing is done for each of these indications. And even though thrombosis is the lowest number here, only 1.5% had a detectable clone when tested for thrombosis, it really does have an outsized effect. And I'll try to convince you in the next few slides that it's really important if we ever see unexplained thrombosis, not just a typical site, that we should consider testing for PNH. Now, thrombosis is a considerable factor in PNH. It's it's the main cause of death, as I'll show you. And PNH is really a prototype of the interactions between complement and coagulation. And I'm reminded of the quote by Oscar Ratnoff that I read about in a recent review by Prysdale, Leatherdale, and Conway, that all of this is really part of a seamless web, and we just test these systems differently. We use different assays in the lab, but it's a big, essentially continuous protection mechanism and homeostatic pathway. And as you can see in this figure to the right, there are really protein interactions between complement, coagulation, and red cell and vascular biology. And I'll just tweak a few of those webs or the strings of the webs for you, just to give you an idea of what we can see in terms of the basic science and translational work before delving more into the clinical. This is work from Leeds a few years ago showing that there is greater clot density and less porosity of a thrombotic mechanism in patients who have untreated PNH compared to controls. This is assay using platelet-poor plasma. And when we add in eculizumab, which is a C5 inhibitor, so blocking terminal complement pathways, you can see quite clearly a reduction in the fibrin density here. And this was similarly measured as much lower as in terms of fibers per 100 microns and a greater porosity again. And this also was shown with reduced thrombin generation, lower levels of fibrinogen as well, and this persisted and became more different over time, and less thrombotic progression, greater lag time as well when we block a terminal complement. If we look at the complement component of this web, I can't come to Vancouver without showing this really great figure that really tweaked my interest back in 2012. So Michael Krissinger from the Conway lab showed this, that in the presence of thrombin can cleave C5 at a different binding site or cleavage site, forming C5bt or C5b thrombin, which can participate in formation of the membrane attack complex, but this membrane attack complex is even more lytic than the standard. And it's pointed out certainly in the paper that there may be rare physiologic situations where all of this may happen, but in a situation where you have a lot of thrombin and a lot of complement activation, that's PNH. So if there is a disease where this could really contribute to that really prothrombotic state, we're talking about it right now. And lastly, this is a fairly recent paper from Christoph Schmidt's lab in Germany, in Ulm, and they showed really that there needs to be, or proposed that there needs to be hemolysis for thrombosis to occur in PNH and other such conditions. So what they started with were complement activation assays using artificial surface exposure, and so there was increased C3a and C5a, even soluble C5b9, and this could all be blocked by CP40, which is a second generation C3 inhibitor. There was even increased expression of complement receptor 3 components and L-selectin on neutrophils, but this did not lead to any increased activity or suggestion of greater thrombotic activity. Platelet count didn't change, standard coagulation parameters didn't really change. The only way to really activate platelets in this model was adding in an intravascular danger signal, if you will, ADP. And so this is shown here looking at P-selectin expression. And then using a human blood model, there was a clear correlation between the degree of hemolysis using different parameters, CD62P or P-selectin expression, and you can see also complement activation at the same time with elevated C3a and 5a. They also used ravulizumab, which is a C5 inhibitor, to show that this can be essentially controlled in terms of reducing platelet activation, hemolysis, and 5a expression. So all of that said, what do we see in the clinic? Lucio Luzzatto, who's a grandfather of PNH, is quite famous for saying that PNH is the most vicious acquired thrombophilic state known in medicine, and I know it's dangerous to say that at a thrombosis or a blood conference, but I think PNH is a contender here. Untreated, we know that up to 45% of our patients will develop thrombosis, and there is a greater risk of this as the granulocyte clone size increases. And Claire Hall showed this back 20 years ago in the Leeds cohort, showing that patients who have a granulocyte clone greater than 50% had a 44% 10-year incidence of thrombosis, compared to around 6% if you had less than 50%. And this is important because thrombosis remains a leading cause of death for our patients. Up to 67% will die from thrombosis if they're not treated appropriately, and the risk of death increases 5 to 10-fold after that initial thrombotic event. Atypical site thrombosis is certainly much more common in PNH than you would see in a standard thrombosis clinic, absolutely. However, standard bread and butter PE and DVT will still occur in these patients, so should not be overlooked, and arterial events can also occur as well. Here in about 15%, there are other distributions that show up to 30%, including cerebrovascular and cardiac involvement. And it's important to think about more than just the clot that we identify initially. When a PNH patient presents with thrombosis, 1 in 5 of them will have a multi-site thrombosis. And though it might not change the initial anticoagulant plan for these patients, it's important to know where those other clots might be in terms of possible end organ damage over time. We recently used the International PNH Registry to look at other features of thrombosis risk, and a fairly new concept of high disease activity around since about 2017 is one of the features that we looked at. And this is really a simple assessment. You need to show that there's elevated LDH, which is a marker of intravascular hemolysis, and at least one clinical manifestation of the disease. And these are broad fatigue, anemia, abdominal pain, dysphagia. And so by having just high disease activity, the risk of thrombosis, the odds ratio was 3 in this analysis, and as the number of those manifestations increase, as you can see here, 2 to 3, and then 4 or more, the odds for developing thrombosis increases to 6 and almost to 12. In addition, not surprising to anyone in the room, probably a history of thrombosis is also a predictor of recurrent thrombotic events. And lastly, which came out of this analysis, and we had to be very careful in terms of how we wrote this in the manuscript, use of anticoagulation was a risk factor for developing thrombosis, which I think just points to the fact that we are good at identifying those patients who may be at higher risk of thrombosis. And what it also shows us is that anticoagulation alone is not sufficient to protect our patients. So how should we protect our patients? Well, eculizumab, as I mentioned earlier, this is a C5 inhibitor. We've had it in Canada since 2009 and more globally since 2007. And this is a composite slide showing you the intravascular hemolysis using LDH as a surrogate. And quite rapidly, you can see improvement in LDH within the first few weeks of treating patients. And this is really a sustained effect as long as they remain on therapy. And over time, we have learned that this has improved survival. To put this in context, on the left you can see a natural history paper from 1995, so well before we had eculizumab available. And despite best supportive care at that time, the 5-year mortality rate for patients with PNH was 35%. And this is a non-malignant condition that affects primarily people diagnosed in their 30s to 50s. Now, if you look at this, we can see almost overlapping survival curves between the UK age and sex match controls and those patients who are treated with eculizumab, the C5 inhibitor, with a slight drop-off, particularly around 10 years, which is due to progressive bone marrow failure. And I would propose that much of the improved survival we've seen over these last now 20 years of eculizumab experience is due to protection against thrombosis. And this early paper even showed this, combining the pilot study, the Triumph and Shepherd landmark trials, and an extension trial into which all patients were eligible to enroll. Looking at thrombotic events per 100 patient years, there was an 85% relative risk reduction, and that was even higher for patients who came into these trials with a history of thrombosis. Recently, we've also done a repeat and updated analysis of survival using a slightly different type of analysis looking at eculizumab treated time and untreated time, and it wasn't a surprise to any of us really that patients do better when they're on a C5 inhibitor if they have hemolytic PNH, with an overall survival hazard ratio of 0.51, so essentially 49% improvement, and much of that improved survival is due to or is driven by those patients who do have high disease activity. And in that same paper, we also confirmed really that patients remain protected from thrombotic events with 60% protection in those patients who are untreated or compared to those who are untreated. Now, eculizumab is no longer the only kid on the block. This figure from Kulasekararaj and Lozana earlier this year shows you just the number of new drugs that are being tested and considered for treating this ultra-rare disease. Still a lot of interest in C5 inhibition, and I'll touch on ravulizumab, which is a new therapy we should hopefully have in the country fairly soon. But crovalimab and pozelimab and cemdisiran are subcutaneous approaches to treating patients, so reducing that treatment burden, hopefully. C3 inhibition with pegcetacoplan. This is the first non-C5 inhibitor to be approved for treatment of PNH, and its main indication is going to be those who remain persistently anemic due to extravascular hemolysis, which we in fact cause iatrogenically when we put somebody on a C5 inhibitor, and factor D and factor B inhibitors. These are small molecule oral inhibitors that are being tested that are blocking factor D and factor B, which are two molecules early on in the alternative pathway. So first, looking at ravulizumab, this is the modified eculizumab. It lasts longer. Essentially, it circulates via the neonatal FC receptor, and it can be dosed every 8 weeks as opposed to every 2. So again, reducing that treatment burden for our patients. And importantly, in addition to that, is that they are protected from breakthrough hemolysis, which essentially is a return of intravascular hemolysis after a period of control. And what you can clearly see here looking at a free C5 assay is that the patients in the ravulizumab arms had no excursions of elevated free C5 throughout the trial period compared to the eculizumab arm, where there were several patients at various time points who did have those excursions above that 0.5 microgram per mil rate. And that really translated into no pharmacokinetic breakthrough events in the ravulizumab arm, where there were some in those who remained on standard dose eculizumab. Now, C5 inhibition is really central to what we've done over the last 20 years, but C5 inhibition drives extravascular escape. If you look at this cartoon, we have eculizumab here, but this could be any C5 inhibitor, which is actively blocking membrane attack complex deposition. It's blocking that intravascular hemolysis, but Keep in mind again that those cells are circulating, they're abnormal, they're missing proximal CD55 regulators as well, and so over time they could get more and more C3 and its split products deposited on the surface, marking them opsonically for essentially extravascular hemolysis. So theoretically, if we block earlier on, if we block at C3 or even in the alternative pathway, we can attenuate or even eliminate that effect. And we've seen that now over the last few years. This is from the Pegasus trial comparing pegcetacoplan, the C3 inhibitor, to eculizumab. This is a phase 2 data of mirikaptan, which is a factor D inhibitor oral drug, and this is a combination or a comparison of iptacopan, which is a factor B inhibitor, also an oral drug compared to eculizumab. And what we're seeing in general is a 30 to 40 gram per liter improvement in hemoglobin in these patients who are on proximal inhibitors, which is quite impressive, and patients, as you might suspect, feel phenomenal when they start this. But what we don't yet know is, are these patients still as protected against thrombosis as they should be and as we know they are on a C5 inhibitor? Now, there are some early data from the pegcetacoplan trial suggesting that there is still a low rate of thrombosis, which is encouraging, but it's very early days, and we have less data from the other trials. So to wrap up just very briefly, this is a very simple algorithm, or not even an algorithm, for how to manage thrombosis in PNH. Obviously, prevention is better than treatment, and to prevent, we would need to start a complement inhibitor in these patients. If we can't, sometimes they do not meet all of the criteria as put forward by ministries of health, we would often anticoagulate them with at least a prophylactic dose, particularly if they have those higher risk factors of disease like high disease activity. If they come in to your clinic and they already have an established thrombotic event prior to starting complement inhibition, we are still typically continuing anticoagulation, although there is some change in practice, particularly some early data from Hopkins suggesting that it may be safe to stop anticoagulation in people who have had a thrombotic event as long as they are well controlled on a C5 inhibitor. What we don't want to see, of course, is new thrombosis while a patient is on a complement inhibitor, and in those situations we would, of course, as we would always do, search for a provoking factor. Did they miss a dose, particularly if it's a self-administered therapy? Is there a complement amplifying condition that needs to be addressed and treated? Are they pregnant? Have they developed an infection? Have they had a recent vaccination? So all of that would come into play. And lastly, just the tool I mentioned, this is a multi-industry partner registry that we are in the process of developing that would allow us to essentially monitor and follow PNH patients regardless of the therapy they're on, regardless of the company that makes their drug. And this is going to be a change from what we currently have available to us, which will permit us to really allow patients to be followed long-term. We can monitor changes in drugs or even combinations and look at infrequent events like thrombosis and thankfully breakthrough hemolysis, and particularly look at outcomes in vulnerable populations like pregnancy that, of course, were not addressed in clinical trials. So with that, I hope I've convinced you that PNH is a rare complement-mediated hemolytic disease with increased thrombosis risk, and we need to keep a high index of suspicion and a low threshold for testing. Thrombosis remains a major cause of morbidity and death in our patients, and there are some risk factors that we can look to suggest that risk, and we know that terminal complement blockade reduces that potential for our patients. There are many novel therapeutics at various stages of development or even approval, as I've shown, and after optimizing safety and therapy, we want to increase that hemoglobin, make them feel better, and reduce treatment burden. And the implications of thrombosis, however, still remain an open question, and hopefully we can use our new registry to answer those questions in the near future. So with that, I'll end, and thank you again for the opportunity.
Thank you. That was a great overview. I wonder if you have a sense for, in terms of the mechanism of thrombosis, whether it's primarily due to the sudden release of hemoglobin into the plasma, or more to the constant activation of the complement system, possibly with some innocent bystander effects on platelets and endothelium, et cetera?
So I would suspect essentially that and it's a fantastic question, and the short answer is I don't know, and it's probably a combination. There is probably low-level activity that is always increasing that potential for patients to develop thrombotic events, but just anecdotally and based on registry data and series, the number of thrombotic events certainly increases in situations where there's an acute attack, so one of those paroxysms really. So there is likely something in the acute period that really drives that, and it may be related to that release of ATP, but there are so many different mechanisms potentially at play that I'm not sure if I could isolate just one.
And do you know if other cells, if complement fragments are seen on other cells that aren't red cells?
Yeah, so certainly, so what I didn't really go into in much detail is that the PNH clone or the GPI negative clones are really expressed on white cells, platelets, as well as red cells. And platelets we don't test in the lab. I'm not a flow cytometrist, but certainly I've heard that trying to do flow cytometry on platelets can be quite challenging. But typically, when it has been done experimentally, the platelet proportion of PNH cells is similar to what you see in the white cells, and if you have a very large platelet proportion, we know that they are much more apt at generating procoagulant microparticles and thrombin generation than platelets from normal controls.
I saw on one of your contraindications for treatment was, or one of the thresholds was LDL levels. Can you elaborate a bit on that? Is that
LDH, yeah.
Oh, LDH.
LDH, yes, yeah.
Okay.
Yes, yeah, and so that essentially is just, again, a surrogate marker of intravascular hemolysis, yeah.
A question here.
Yes.
What's the molecular mechanism of bone marrow failure, and would transplant make sense?
Yeah, so the general idea, and this is still a bit debated, but the idea is that these mutations, this PIGA mutation, can establish itself in a hematopoietic stem cell, and we may all have some of those, but in a normal functioning bone marrow niche, that typically does not expose itself, but in situations where there may be a trigger like an infection or an autoimmune process that disproportionately targets normal stem cells, that can allow that PNH clone to expand. It's still a bit debated whether or not that's just stochastic expansion or if there are actually specific kind of features that aid that in terms of increased survival. But that's really where it comes from. But there's a very close association between PNH and aplastic anemia, and less so in hypoplastic MDS, but they theoretically are operating on a bit of a spectrum there. Did I answer that question?
No transplant.
Okay, so for transplant, transplant is certainly indicated in situations where it would otherwise be indicated. So progressive marrow failure is certainly the main indication. Occasionally, it's been done for patients who have no response to C5 inhibition and have persistent hemolysis. A large French series, however, looked at other indications like a more thrombotic phenotype, and those patients did worse with transplant. So in those situations, we would just manage them supportively, but thankfully there are other therapies most of the time that we can offer.
Chris, are there criteria that you've established to define a thrombosis of, an unexplained thrombosis that would trigger, flow cytometry studies?
Yeah, well, so what we tend to recommend is any time that there is a atypical site that you can't otherwise explain, due to obstruction or evidence of malignancy or something else on scan, but also typical site thrombosis that is behaving differently. Perhaps it's progressing through anticoagulation, it's recurrent, happening in younger patients, and also in situations where they may also express one of those other catch criteria, so evidence of throwing an LDH on to see if there's some hemolysis may help. If there are other cytopenias in the context of a thrombotic event, that would be another time we would do it. I'm obviously biased, but I tend to say anytime you can't fully, if something feels abnormal in the context of a thrombotic presentation, it doesn't hurt to do it. It's a simple and fairly inexpensive test, and if you find a positive, you have therapies that can drastically change outcomes.
I think we should.
Okay. Yeah.
So thank you very much.
Thank you very much.